Hello, this is Dr. April Armstrong. I'm professor of dermatology and associate dean from the University of Southern California in Los Angeles. Welcome to this unique educational activity focused on the role of IL-17 inhibitors in the treatment of moderate to severe psoriasis. Dynamic animations and a video will be also used to highlight the rationale for targeting IL-17 as a therapeutic strategy in psoriasis. And a video of a patient from my practice will exemplify the impact of psoriasis on our patients' quality of life.
Hi, I'm Heather Carrasco, and I'm a patient of Dr. Armstrong's. So I initially had my first symptoms when I was in middle school. I can remember having my headgear on for my braces and having to scratch at my scalp a lot. It was itching, and I had like flakes that would come off. So my hair was super flaky. That's why I thought it was dandruff. And in hindsight, I know that I had scale that I was picking off, but at the time I didn't realize what it was. And it was painful, but I think that it was painful because of how much I was messing with it at the time. So I tried different things so that I could not have issues, right? Like different shampoos, and things would be fine for a while. And so I would figure that I had found whatever the magic key was. Um, and then eventually it would start getting worse again. So it didn't really impact me that severely when I was younger, like middle school and high school and college. It wasn't until later that it started to impact my life a little bit more. When it started to spread to my arms and my legs, then that's when I decided to go see a doctor to find out what was going on. So I went to a dermatologist. I figured that it was eczema that was showing up, and the doctor told me that I had psoriasis. It didn't really mean anything to me at the time. He gave me some creams and lotions to use for it, and set me on my way. I really had no sense of kind of the impact that it might eventually have. And obviously, for some patients, that is where it stops, is that they have some patches, and that's the end of it for them. And it's really manageable. Mine eventually got worse, but it didn't occur to me at the time that that was something that could happen. And ultimately, as my scalp got worse and as the lesions on my body got worse, I ended up switching doctors and going to somebody else who offered me other therapies. So I tried for a while for my skin, the phototherapy machines that you can have at home. So I tried that for a while, but eventually the amount of coverage on my skin was too much for me to handle doing that for 2 or 3 times a week. I forget what the frequency was, because it would take me so long. Around that same time, I ended up being diagnosed with psoriatic arthritis. And so I started taking biologic treatments for that, which helped to control my psoriasis, especially for a time, until I ended up not using those anymore for a brief period of time because I was pregnant, and my doctors had decided that they didn't want me to use those medications while I was pregnant. And so after the birth of my second kid, I I ended up in what felt like a whole body flare. It was the worst pain and experience um, I've probably ever experienced. My entire back was covered. Most of my torso was covered, my legs, my arms, in addition to my scalp. And I think what finally pushed me over the edge of like, creams are not going to work. None of this is working. And I have to do something was I was uncomfortable every single day. didn't matter what I wore, I was uncomfortable because everything rubbed against the lesions. So it was painful, it was itchy, everything was uncomfortable. And so I ended up going in and seeking different type of treatment. I was kind of like, what can I do? What are the options here? What can potentially help with this? And that's when I started on the current regimen that I'm on, which is a IL-17 inhibitor.
As you have heard from Heather, the burden of psoriasis really affects her and her family in ways that are beyond physical. Therefore, it is even more important that we understand how to treat our patients with psoriasis. Psoriasis is a chronic immune-mediated inflammatory skin disease that affects more than 8 million Americans. Psoriasis typically begins between the age of 15 and 35 and oftentimes requires lifelong management and support. Overall, patients with psoriasis experience a reduction in their quality of life, similar to or worse than patients with other chronic diseases such as ischemic heart disease and diabetes. In addition to the functional, psychological, and social burden related to psoriasis, medical resource utilization and healthcare costs have also been reported to be substantial. It is estimated that $112 billion per year are spent on caring for patients with psoriasis, as well as from loss of productivity from either absenteeism or presenteeism at work. It is now recognized that the manifestations of psoriasis can occur beyond the skin. Patients with psoriasis show an increased prevalence of comorbid conditions, including cardiovascular diseases, metabolic syndrome, obesity, and psoriatic arthritis. They also have a greater likelihood of psychological disorders, particularly anxiety and depression. In turn, these physical and psychological comorbidities are associated with reduced quality of life, social stigmatism, high stress levels, physical limitations, low self-esteem, and employment difficulties. Here is a study that looked at multidimensional assessment of burden of psoriasis. Overall, 525 dermatologists and nearly 4,000 psoriasis patients from 9 countries participated. First, psoriasis patients with comorbidities, such as psoriatic arthritis and cardiometabolic comorbidities, have worse physical and mental functioning compared to psoriasis patients without comorbidities. This was measured by SF12. Second, psoriasis patients with comorbidities experienced worse quality of life and greater work impairment compared to those without comorbidities. In addition, the presence of greater severity of itch was associated with decreased physical functioning, mental functioning, quality of life, and work productivity. Many psoriasis patients may have lesions involving visible areas, such as the face or hands, and some may also have lesions in the sensitive areas, such as the genitalia. These patients with lesions on visible and sensitive skin areas are more likely to have decreased quality of life and increased medical resource use. Now let's talk about signs and symptoms of psoriasis. In patients with plaque psoriasis, the most common signs are thick, red, and raised patches and plaques on the skin. They're oftentimes covered by a silvery white scale, and they tend to itch. In addition to that, what patients see and feel tends to vary with the type of psoriasis present, places psoriasis appear on the body, and the amount of psoriasis that a patient has. Here are the major subtypes of psoriasis, and it is important to note that these subtypes of psoriasis are classified by morphology, and they are chronic plaque psoriasis, which is the most common type, guttate psoriasis, pustular psoriasis, and erythrodermic psoriasis. Now, let's talk about other types of psoriasis that are classified by location. First, inverse psoriasis. Inverse or intertriginous psoriasis involving the skin folds. Those involve the inguinal areas, perineal, genital, intergluteal, axillary, and inframammary regions. It's called inverse because psoriasis presentation in those skin folds is the reverse of the typical presentation of plaque psoriasis on extensor surfaces. Characteristic findings of inverse psoriasis include well-demarcated, smooth, and shiny plaques with absent or minimal scale, and they can oftentimes be misdiagnosed as intertriginous fungal or bacterial infections. Nail psoriasis can present as pitting, lifting of the nail plate from nail bed, or worse, crumbling of the entire nail plate, as you can see illustrated by these images. Palmar-plantar psoriasis, as the name suggests, involves the palms or soles. Classic presentation consists of red hyperkeratotic plaques that may have associated fissures. Fissures can be quite painful and disabling. Now, palmar-plantar psoriasis can also present in another variant called palmar-plantar pustulosis. And this is a condition where one sees these recurrent pustular eruptions on the palms and soles. There's controversy regarding this particular variant is a subtype of psoriasis or a distinct clinical disease entity. Now let's talk about psoriasis pathogenesis.
Psoriasis, characterized by well-demarcated erythematous and scaly skin plaques that can be disfiguring, pruritic, and painful, involves excessive epidermal growth and aberrant keratinocyte differentiation. In the initial steps of psoriasis pathogenesis, a variety of cell types, including plasmacytoid dendritic cells, keratinocytes, natural killer T cells, and macrophages, secrete cytokines that activate myeloid dendritic cells. Once activated, myeloid dendritic cells migrate into draining lymph nodes and secrete IL-12 and IL-23. IL-12 induces differentiation of naive T cells to Th1 cells. IL-23 is central to the survival and proliferation of Th17 and Th22 cells. Th1 cells secrete interferon gamma and TNF alpha. Th22 cells secrete IL-22, and Th17 cells secrete IL-17, IL-22, and TNF alpha. Among these pathways, IL-23 mediated activation of the Th17 pathway is thought to be predominant. IL-23 signaling is mediated intracellularly via TYK2, JAK2, and STAT3, which leads to transcription of key inflammatory mediators. These cytokines lead to downstream keratinocyte proliferation. Increased expression of angiogenic mediators in endothelial adhesion molecules, and infiltration of immune cells into lesional skin. These recent advancements in the understanding of psoriasis pathophysiology have resulted in the development of targeted biologic therapies. As noted, the IL-23 Th17 pathway has been identified as a critical axis, and the pro-inflammatory cytokine interleukin-17A is its primary effector. Secukinumab and Execuzimab, two IL-17A antagonists, have shown high-quality early responses and maintenance of clinical improvement in patients with psoriasis, while brodalumab, which blocks the IL-17 receptor, has exhibited rapid early response as well, especially in patients with a significant inflammatory flare of their psoriasis. The development and approval of these IL-17 inhibitor agents have expanded psoriatic treatment with effective options, validating the importance of the pro-inflammatory role of IL-17 in psoriatic pathophysiology. Biologic treatment options for psoriasis will continue to grow, especially IL-17 and IL-23 related agents, with an increasing specificity of agents to be available in the future.
Now let's talk about the various treatment options for patients with psoriasis. In those with mild psoriasis, the treatment is typically focused on topical therapies, and these include topical corticosteroids, topical vitamin D analogs, calcineurin inhibitors, and localized phototherapy. In those with moderate to severe plaque psoriasis, treatment is typically focused along three arms. One is biologic agents, two is oral systemic therapies, and then three is phototherapy. Here are the approved systemic therapies for psoriasis. TNF alpha inhibitors that are approved for psoriasis include etanercept, infliximab, adalimumab, and certolizumab. And for the IL-23 inhibitors, those include ustekinumab, guselkumab, tildrakizumab, and risankizumab. Here are the currently approved inhibitors for the IL-17 pathway, as I talked about before. It's important to know that brodalumab, execuzumab, and secukinumab are approved for psoriasis in the United States, and execuzumab and secukinumab are also approved for psoriatic arthritis in the US. Brodalumab, while not approved for PSA in the United States, is approved for PSA in other parts of the world. In terms of the mechanism of action, execuzumab and secukinumab target IL-17A, And brodalumab is actually a receptor inhibitor. It targets IL-17 receptor alpha. With regards to dosing, as you can see here, brodalumab is administered every 2 weeks for maintenance, and Execuzimab and Secukinumab are administered every 4 weeks. There are certain considerations when it comes to IL-17 inhibitor use. Typically, in patients with a personal history of inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, we want to avoid the use of IL-17 inhibitors because some patients may experience exacerbation of their inflammatory bowel disease. Other adverse reactions, as you can see, are listed here, are similar to other biologics that are used for psoriasis, which may include injection site reactions, upper respiratory tract infections, and so forth. But overall, the safety profile for IL-17 inhibitors is good, and these medications are well tolerated. And now let's take a look at the key brodalumab clinical trial endpoints. We will focus on the approved dosage for brodalumab, which is 210 milligrams. As you can see, in Imagine-1 trial, at week 12, 83% of the patients will have achieved PASI 75, and about 76% of the patients will achieve clear or almost clear by week 12. So as you can see, this is quite robust efficacy, and these results are also replicated and actually are a bit better in the Imagine-2 study, where it's a brodalumab versus placebo versus ustekinumab. And in Imagine-3 study, as you can see, same efficacy endpoints are seen here with robust efficacy of brodalumab in the skin. And I just want to highlight by week 12, brodalumab 210 milligrams, nearly 40% of the patients will also have achieved PASI 100. So as I talked about before, brodalumab is approved only for psoriasis in the US, but it's approved for psoriatic arthritis outside of the US. And phase 2 randomized placebo-controlled study have shown that at week 12, a greater proportion of brodalumab patients, whether it's 140 milligrams or 280 milligrams, have attained ACR 20 or at least 20% improvement in their joints compared to placebo. But more importantly, at week 24, more than half of the patients receiving brodalumab 140 milligrams and 64% of the patients receiving brodalumab 280 milligrams have achieved ACR 20, and this result is sustained through week 52. Now let's consider Execuzimab results from the pivotal studies. And what we see here is that, again, by week 12, so quite early on, when we are looking at Execuzimab Q2 week arm, this is because Execuzimab for the first 3 months is given every 2 weeks, and after that is given every 4 weeks. So when we look at the approved dosing every Q2 weeks, as you can see that nearly 90% of the patients have achieved PASI 75, and 82% of the patients achieve clear or almost clear by week 12. And the results from Uncover 2 as well as Uncover 3 are very similar to the results that I just discussed. Now, let's talk about Execuzimab with regards to difficult to treat psoriasis. In patients with scalp psoriasis, Execuzimab treated patients achieved psoriasis scalp severity index 90, or at least 90% improvement at week 12. And the proportion of patients that achieved that really high bar is 82% in those that were given Q2 weeks. And this is compared to 55% in the etanercept group and 7.6% in the placebo group. Now, when we think about genital psoriasis, Execuzimab has a dedicated study for patients with moderate to severe genital psoriasis. And at week 12, 73% of Execuzimab subjects achieved clear or almost clear compared to 8% on the placebo. For non-pustular palmar-plantar psoriasis, a greater percentage of patients treated with Execuzimab achieved palmar-plantar psoriasis area and severity index 50, so at least 50% improvement in their palmar-plantar psoriasis by week 12. And specifically, what we see is that in the Execuzimab treated group, 80% of them achieve that compared to 67.8% of patients on etanercept and 32% of the patients on placebo. Now, additionally, Execuzimab also demonstrated efficacy in erythrodermic psoriasis and generalized pustular psoriasis. In a phase 3 open-label study, about 75% of erythrodermic psoriasis patients and 60% of patients with a generalized pustular psoriasis achieved clear or almost clear at week 52. Execuzimab is also highly efficacious in psoriatic arthritis. In a pivotal trial, it was found that a greater proportion of patients treated with execuzimab achieved ACR20 response compared to placebo at week 24. And specifically for the Q2 week dosing, it's 62%. For the Q4 week dosing is 57.9%. This is compared to adalimumab at 57.4% and placebo at 30%. Execuzimab also have shown to improve joint function, and importantly, it has led to significantly less structural damage progression at week 24. In another trial, SPIRIT-2 trial, looking at PsA patients with inadequate response to TNF-alpha inhibitors, what was found is that at week 24, when we're looking at ACR20 or at least 20% improvement in joint symptoms, patients on execuzumab Q2 week dosing, 48% of them achieve ACR20 and 52% of them on the Q4 week dosing achieve ACR20 compared to 20% on the placebo. So as you can see, even in this group of patients who are more difficult to treat, execuzumab was also highly efficacious in psoriatic arthritis. And now let's talk about secukinumab. Secukinumab was the first IL-17 inhibitor that was approved for psoriasis. And there have been a number of different studies that have been published looking at the efficacy of secukinumab in both the skin and joints. Here we see two pivotal studies. They're called erasure and fixture studies, and we're looking at week 12 primary endpoint. And what we see is that by week 12, in the placebo-controlled study of erasure, 81% of the patients on secukinumab 300 milligrams have achieved PASI 75. In addition to that, 65% of the patients on secukinumab 300 milligram group have achieved clear or almost clear by week 12. So as you can see, the medication can act quickly and gain patients significant control after just 12 weeks. In the fixture study, what we see here is very similar results compared to the erasure study. Here are additional studies evaluating the efficacy of secukinumab in psoriasis. As you can see, in these phase 3b studies, secukinumab has robust efficacy regardless of the endpoint that's assessed, whether it's PASI 75, clear or almost clear, or PASI 90. And what was shown, for example, in head-to-head studies, for example, with ustekinumab, about 80% of the patients achieve PASI 90 by week 16 in these secukinumab-treated patients, compared to 57% of the patients in ustekinumab. This also included a head-to-head study of secukinumab versus guselkumab at week 48. And in this study, 70% of the patients on secukinumab have achieved PASI 90 at week 48. Secukinumab has a number of dedicated studies for the difficult-to-treat psoriasis locations, and these studies are actually pretty distinctive and different, unique from most other biologic studies that are done in these special areas, which tend not to be dedicated studies. So with that, we can have really robust evidence to remind us of how secukinumab work in those particular areas, because these are really dedicated studies to look at these different locations. In patients with moderate to severe scalp psoriasis, secukinumab achieved PSSI 90 and clear or almost clear treatment response in 53% and 57% of the patients respectively. And that's compared to 2% or 6% for placebo. So as you can see, it has good response in scalp psoriasis. What about nail psoriasis? Secukinumab really demonstrated significant efficacy over placebo. At week 16, the NAPSI from baseline improved by 45% in secukinumab 300 milligram group, which is pretty notable. In another study, in the GESTURE study with patients with palmar plantar psoriasis, at week 16, 33% of the patients in the secukinumab treated group have achieved clear or almost clear. And then finally, in a 52-week phase 3 open-label study in 12 patients with generalized pustular psoriasis, we know this is a very difficult patient population to recruit. 83% of the patients achieved very much improvement or much improvement. Let's take a look at Secukinumab's efficacy in psoriatic arthritis. There have been 2 pivotal trials that have looked at this issue, and that is Future 1 and Future 2. When we look at Future 2, which looked at subcutaneous secukinumab in patients with PsA, what was found is that a significantly higher ratio of patients receiving secukinumab achieved ACR 20 compared to placebo at week 24. Specifically, those getting secukinumab 300 milligrams, 54% of them, as compared to 51% in those getting 150 milligram of secukinumab, have achieved ACR 20 compared to only 15% in the placebo group. So as you can see, secukinumab is highly efficacious in psoriatic arthritis. There have been a number of other studies that have published on the efficacy of secukinumab on psoriatic arthritis, which have continued to show its ability to inhibit the clinical disease and manifestations in psoriatic arthritis, as well as inhibit the radiographic progression in psoriatic arthritis. Now, let's really sum it up a little bit and think about how we use and select IL-17 inhibitors in the treatment of moderate to severe psoriasis. So, in multiple meta-analyses and head-to-head studies, certain IL-17 inhibitors have demonstrated superiority to different types of IL-23 inhibitors. Now, obviously, the specific type of IL-17 inhibitors is important to look at, and it's different depending on the study. But one thing we noted as an overall trend as a class is that IL-17 inhibitors act very fast. And in the short term, when you want patients to get fast response, IL-17 inhibitors are really unique in being able to give patient that fast response. In addition to that, the long-term efficacy, when we look at IL-17 inhibitors, they're also very much well sustained. And in addition to that, when we look at IL-17 inhibitors, they, as a class, offer a favorable safety profile. One thing to watch out for is not to use them in patients with inflammatory bowel disease, but other than that, they are well tolerated by most patients. A small number of patients may have mucocutaneous candidiasis, which are mild, typically mild and easily treated, and is not a reason for discontinuation for those on IL-17 inhibitors. One of the unique advantages of IL-17 inhibitors is in patients with psoriatic arthritis. IL-17 inhibitor class, as is shown by subsequent head-to-head studies with TNF inhibitors, they have been shown to work at least as well as TNF inhibitors with regards to PsA. So this is important to note. And then finally, additional IL-17 inhibitors are currently in development for the treatment of moderate to severe psoriasis, such as Execuzimab, which really highlights the importance of this IL-17 pathway, the Th17 pathway, and the role of IL-17 in the pathogenesis of psoriasis. And now let's hear from Heather again, my patient, on her perspective on the patient-provider relationship.
Yeah, I think that getting a sense from patients about the level of pain or discomfort or itchiness or anything like that that they're going through, I think is helpful. The first dermatologist who diagnosed me, I don't recall him asking me any questions about how severe it felt. It was just okay, yeah, you have this small patch, put this cream on it, let's move on. Whereas I feel like since then, right, my experiences with Dr. Armstrong in particular, she asks quite a bit about the level of discomfort that I have. And I think that that can really play a role in how you might want to treat the psoriasis, because if it is painful enough and uncomfortable enough that it's impacting somebody's daily life to any degree, then I think that being a little bit more aggressive or considering other treatment alternatives is definitely something that should be on the table. And without asking those questions, I don't know how you would know, because I don't know that a patient is necessarily going to volunteer some of that or realize that they should be volunteering some of that information, because they might think that it's just part of it and that the doctor is just going to automatically know that they're uncomfortable. or that it's really itchy or that it's painful. I think I would say that they should do some of their own research, and and even if you're not going to participate, get into some of the online forums so that you can read about what other people are going through. Because in some cases, I've learned about new potential therapies by reading about what other people are going through, how other people are treating their psoriasis, talking to other people. I had joined a group that was associated with the Psoriasis Foundation for a while, and that was super helpful. That was how I learned about the phototherapy machines that you could use at home. Um, so there were things like that that I think will help to further your education about the disease. And that I think goes back a little bit to the doctors as well, is making sure that they're communicating when, especially if somebody's newly diagnosed, that there are resources available and that they should potentially look into them, and do some research on their own so that they understand not only what some of the treatment options are, but also some things that they might want to be keeping an eye out in their own health so that they know whether or not to bring something up later down the line, to know that it is a sign of their condition worsening or it's a sign of something else happening, um, and not just ignoring something. Even if somebody is doing good and maybe not perfect with whatever they're on now, I feel like knowing that there are other things that could be done is something that's worth looking into. Let's see if we can get to 100% clear, right? And so for me, I'm always, and maybe that's just me, but I would always want to know that there are other options, that there are newer options that might do a better job of treating the disease. And I would be willing to try them in order to try to get to that dream of not having any part of my skin impacted.
That ends our discussion for today. I hope you found the activity informative and useful to your practice. I also encourage you to access the supplemental materials for additional information. Thank you very much for participating.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.